I'll start by saying thank you to all of you for typing in where you're from. Um, we have Puerto Rico, Denver, Philly, Los Angeles, Washington State, people from all over the nation, Idaho, Oregon. Last time we've had some folks from Guam and Nigeria join us. So it's great to have you all here tonight. Some very strange happenings in our country, and some of you folks have typed in about that. And yet we carry on the work that we do, and thank you all for making the time to be here. So welcome to the next in a series. This one tonight is called Clinical Engagement and Telemental Health. This is the fourth of a six-part series. My name is David Jefferson. I've been your facilitator for the last 4 times, and we're very excited. Dr. Sarah Smucker-Barnwell is back, and she's put together a fantastic presentation to teach us more about engagement and telehealth. Also, many of you have participated before, but some of you, this might be your first night. And if this is your first night, would you just type in the chat box and say new? And that kind of gives us a little sense about, is there 10 people new or 20 or something? And we'll watch that and go, okay. So then we'll give us an idea about what to add and what not to add. So thank you. Like seeing all the new faces, and welcome to all the folks that have been here before. So before we get started, on the next slide, I'd like to talk about the importance of words, and I guess that couldn't be more important than the times that we live in right now. And we want to make sure that the work we do is backed with equity, and we are using words that represent that. We all know that there's words that don't represent that very well. So that matters a lot to us. Some housekeeping items next. In the chat box throughout the evening, please submit the questions for Sarah, and I'll gather all those. Sarah's going to stop at a couple different spots. We'll gather up some questions, we'll answer those, and then we'll kind of keep going. And then at the end of the evening, if there's a few more questions that don't get answered, we'll also put that into a frequently asked question document that we're in the process of developing. We'll also have a survey at the end of the evening. I'll put that link in the chat box. But in addition to that, you're going to get a follow-up email in the morning that will also include the link. It's pretty important to us. We'd like to know how we're doing, and if there's something in particular that we should be doing more of, we'd sure like to know about that. Okay, like I said, here is one way that you can give us feedback is through our northwest@attc web email address, which I'll also put in the box for you. And I also wanted to say that Sarah set up a Gmail account so that you can email her directly if there's a particular question you want to ask. And she's also been gathering those too as a way to get information in between the different sessions. So I'll put that email up there for you too as we move along. Okay, and I think that is. Next, I'd like to introduce Dr. Sarah Smucker-Barnwell. Got to make sure that we get that exactly right. She is a licensed clinical psychologist who provides evidence-based psychotherapy and consultation in the greater Seattle East Side area. Her research and publication focus on the ethical intersection of technology and evidence-based therapies. Dr. Smucker-Barnwell is a partner in Seattle Psychologist. He's a former director of telehealth training and education for the VA and Puget Sound healthcare system. With that, I would like you all to welcome Sarah. I think you're all in for a treat this evening. And again, keep the questions coming. And Sarah, I'll turn it over to you.
Thanks so much, David. And thanks everyone for joining this evening. If this is your first time, welcome. I saw some new prompts popping up in the text box, and thanks to everyone who is returning. This is the fourth in a series dedicated to telemental health. This evening, we're going to be focusing on clinical engagement in telemental health. And while I will very briefly review some of the themes we've spoken about previously, I am endeavoring to kind of build on and scaffold from previous classes. So, if at some point there's something that isn't well explained or you have a question, feel free to put it in that chat box and we'll do our best to address it. I do make an effort to go back and review some of the content from prior classes, but really also try to make sure there's lots of new things to talk about, new things to learn tonight. And as David mentioned, all of the classes, should you be interested, will be available on demand online. So I'm Sarah. I'm a clinical psychologist in Seattle, Washington, and I've had this really fortunate career in which I've been able to focus in the area I'm really passionate about, telemental health. Previously, I was the director of telemental health for VA Puget Sound healthcare systems, and then later had the opportunity to oversee training and education in that same healthcare system. And it was really just a wonderful experience, bringing evidence-based mental health care to clients who otherwise might not receive it. And to me, this is really at the heart of telemental health. This is why we do this work, making sure that we bring the wonderful work that you deliver to clients when and where they need it, which is an issue that could not be more salient today. I had the pleasure of contributing to the American Psychological Association telepsychology guidelines, as well as other telepsychology guidelines for the American Telemedicine Association and other entities. I'm a former Center for Excellence in Substance Abuse Training and Education fellow at the VA Puget Sound, and that was my training, and my research was in addictions research and intersectionality with telehealth. So this is really an exciting group for me to get to speak with. And I joke every time, I'm an unapologetic telehealth evangelist. So I really love this modality, which is not to say I don't recognize its limitations and its challenges, but is to say that I believe it has a lot to offer us. And I hope that I can convince you of that too. Okay, so tonight we're going to speak a bit about clinical engagement broadly, and really talk about its importance in the context of telemental health and what are the environmental factors that we can control to help bring those wonderful clinical skills that you demonstrate every day with your clients to a distance milieu. What are the behavioral factors? What can we do, with our faces and our bodies to help really, again, bring that connection and that rapport, that therapeutic alliance that we know is so important for good care. In terms of the structure, I'll be talking a lot. There'll be a lecture component, but not to worry, I'll be taking lots of breaks with live Q&A at 3 different times through our time together. We're going to have quite a few video demonstrations today. And I did this perhaps more than other classes because I think some of these themes, while we can discuss them and I can explain them, I can write them on a slide, it's much more easily seen. So it's my hope that through these videos, it will help clarify some of the themes we're talking about. As David mentioned, I do maintain this NWATTC telehealth at gmail.com address. If you have a question that is not answered in our live Q&A, please know I do look through the chat logs and endeavor to make sure that those questions are answered in the following class. But if there's something you just really wanted to know and we didn't get a chance to get to it, please don't hesitate to send me a message. I like hearing from folks and I usually get back within a day or so. And then, of course, we'll conclude, as we often do, with a final live Q&A. I always joke that if you're giving a presentation on technology, inevitably your technology will fail and embarrass you. So I now have it in my disclaimers. And really, I'm here to offer my best practice recommendations based on my own clinical work, my review of the literature as it stands today, and my experience in regulation and policy creation. I'm endeavoring to identify best practices and guidance in a developing area, though not necessarily delivering you a specific standard of care that always must be observed. So the always of it is you always review your state regulations. Each of us, it seems we have this wonderful group that comes from all over, and we're going to have different rules and regulations that are relevant to our practices. So we want to check in with our state or jurisdictional regulations. We want to check in if we have legal counsel or a risk manager in our lives through our malpractice insurance or perhaps our workplace. We want to check in with them. If you do happen to carry malpractice insurance, many of them have a wonderful service. I know I work a great deal with the American Insurance Trust, and they have an advocate service where you can talk to attorneys on their staff and they give you free advice, and it's pretty great. So if you have something like that, I always encourage folks who are just engaging in telemental health for the first time, set up a call. Ask them if there's anything specific to your jurisdiction that they would advise. And my other dorky joke is I do not provide legal counsel nor clinical standards of care. I'm not a wealthy lady. Please don't sue me. Okay. All right. Conflicts. We should always disclose our potential conflicts of interest. I do like to mention that in another part of my life, I deliver telehealth training, much like this, and other places. And so, I guess one could say that I have a horse in the race, and that if telehealth becomes wildly successful and popular, I suppose I would benefit from that. But again, I did already disclose I'm a known telehealth evangelist. I really am a believer in what this modality can do for our clients and how it can help democratize good care and get care to those who need it. Okay, so our agenda for today. I want to spend a little bit of time just broadly speaking about clinical engagement and why it is an important theme. And then we'll talk a little bit about those environmental factors, our location, the technology we're using. We'll talk about those behavioral factors, both for provider as well as for client. And, as always, we're trying to find this balance. We're really threading a needle where we're trying to um, give some brief reviews. So for those folks just joining that, we're making sure that they get the basics, but really going on to deep dives. So we've spoken about clinical engagement in prior classes in this series, but it's my hope today to really get into the minutia of how we can really bring those, what we might call soft skills, those clinical skills, to life in a distance modality. We're going to be focusing a fair bit today on video conferencing, but we'll also be sure to talk about telephone and other modalities as well. But I will say we will be video heavy. Of course, we're always trying to answer questions as they emerge. And sometimes I may direct folks to prior classes if there is just if I think they're looking for a deeper dive on a prior theme. So let's talk about some of those operational definitions. We'll go quickly because, again, folks who've been here previously have heard this. Telemental health, the provision of any mental health service using telecommunications technologies. You'll often see it as TMH. This can be used synonymously with words like telehealth or video teleconferencing or telepsychology or telesocial work or whatever various discipline we might be in. All of these are relevant to telemental health. And really, technically speaking, because this refers to any technology, this could refer to email, this could refer to a telephone call, this could refer to text or secure messaging. And what most people mean when they say TMH or telemental health is video conferencing. So, for our purposes, we'll use this in this way, speaking in a somewhat synonymous fashion with video conferencing. But I also think the telephone is the unsung hero, so we'll stick up for the telephone a bit as well. And again, I can't say this enough. Telemental health had its roots in rural health and, access to care. And I really just can't say enough. We're in this throes of a pandemic and, important things going on in our country from in terms of equity and, and unrest as well. And I think now more than ever, just making sure that we are reaching out and building community and being present as mental health care providers is incredibly important. So I really believe in telemental health, perhaps now more than ever. HIPAA, that federal regulation that makes sure the information that we speak about with clients remains private as well as secure. And just, I always include this slide so folks understand that the information that we share in the telemental health milieu continues to be relevant. HIPAA continues to have relevance. We are still required to protect that protected health information or electronic protected health information, PHI or ePHI, which, as you can see here, encompasses a diversity of themes, many of which, I previously had known as a clinician, got to keep clients' names private. That one I knew, but there were others that emerge, that I think are specific to the telehealth milieu, such as URLs or IP addresses or device or serial numbers if we are using hardware for healthcare. So just being really thoughtful that all of these fall under the rubric of PHI. Business Associates Agreement, that's that contract between HIPAA-covered entities and HIPAA business associates that makes sure that partnership, that all partners in the partnership are respecting HIPAA. So if I'm going to get a video conferencing product, if I'm going to get an electronic medical record, themes we've talked about in prior courses, I want to make sure they give me that BAA to make sure that they, like me, are going to respect the rules of HIPAA. And again, we want to think about this as one tool of many that we can help to reach out to clients during a period of time where many of us may have stay-home orders or other restrictions in our jurisdictions to help keep us healthy and safe. Okay, on to some new content here. Thanks so much for coming tonight to talk about clinical engagement in telemental health. This evening, I'm going to be co-hosting this class with a slightly younger version of myself. That is to say, I'm going to be having quite a few demonstration videos. And why do I do that? Why do it here and not other places quite as much? The reason being, I think that there is an opportunity through videos and through demonstration to give life to some of the ideas that we've talked about in prior classes. Perhaps the easiest example that I could use is eye contact. Eye contact is something we talk about probably almost every class in telemental health, because it's a known issue that when we are looking at where our client is on the screen, our eyes appear cast downward. When we look into the camera, we appear to make eye contact with where the client is. Now, I could describe that for you, but showing you is a lot easier. So tonight we're going to have a lot of demonstration videos that articulate some of these themes and hopefully bring them, to sort of a good visualization that's helpful. So a brief synopsis. We're really going to go through just 3 slides for all the themes that, could encompass many, many hours. And again, if this is your first time, I'd encourage you go back to those prior classes where we talk about video conferencing calls. But a brief synopsis. Once more, we're talking about video conferencing appointments today, and we're going to be talking as though we are using a product that is designed for healthcare and that offers us that BAA, acknowledging there are other products we are now, because of an executive order, permitted to use, such as Skype or FaceTime or the non-PHI version of Zoom. But for our intents and purposes, we're going to assume we're using a product designed for healthcare. Before we're seeing the client, we have obtained informed consent that includes specific informed consent for telemental health, the risks and benefits of meeting remotely. We have cultivated an emergency plan with the client and reviewed it with them. And we have documented all of this in the chart, not only because it helps our client to understand what to expect for their care, but it also helps to manage our risk and really set us up to succeed for a good telemental health appointment. We have assessed the client's appropriateness for the telemental health milieu, understanding that this will be an ongoing process. This isn't something we just do once. We have checked our jurisdictional rules to ensure that our jurisdiction is permitting telemental health, that there are no additional rules, any considerations. I will say, especially right now, pretty much every jurisdiction I'm aware of is permitting telemental health, and many have relaxed barriers to make it even more accessible. If you are looking for a resource to review your jurisdiction, the ASPPB, and I'll ask David to put that in the chat window, the Association of State and Provincial Psychology Boards, go over some of the psychology board orders, as well as some of the state executive orders. And I think it's relevant to psychologists, of course, but I think it's relevant to people in other disciplines as well, because it reviews some of those executive orders state by state in terms of any changes they've made to regulation to facilitate mental health care. And of course, we've talked in prior meetings how to prepare our offices, especially our home offices, to be successful in telemental health. And we'll talk a little bit about how that impacts clinical engagement today. We've thought about what services we want to provide to clients, what clients we're going to serve over telemental health, and we've thought about themes like how we're going to transfer documents. How are we going to get that informed consent document back and forth? How are we going to, exchange homework back and forth? We've thought about how we're going to communicate in between sessions. Again, it doesn't need to be a high-tech solution. The telephone works great. Or maybe we have a secure message program. Maybe because of some of the relaxations of HIPAA in the current environment for COVID-19, we determined we'll use an email. And we've thought about how we're going to secure payment from our client and send them the necessary documentation for insurance reimbursement or submit to insurance. Okay, that's a lot quickly. But again, we're trying to find this balance so we can focus on one topic at hand. So please, if during the Q&A session something is just really outstanding, we'll have a chance to get to it. And I may direct folks back to prior classes where we do a deep dive on some of these other themes. Let's talk about clinical engagement, because that's what we're here to talk about tonight. Clinical engagement, we know that enhancing rapport and therapeutic alliance impacts clinical outcomes. This is really well documented in diverse research across demographic groups of clients, across clinical diagnoses, and across treatment modalities and interventions. We find that having a good rapport with your therapist, simply stated, improves your outcomes. It predisposes you to have a better outcome. One of my favorite studies, and this is quite old, I mean, there's been newer research, but is that MATCH study from years ago where, they were going to finally settle the question of who was right, so to speak. Was it the cognitive behavioral therapists? Was it the psychoanalysts, or folks doing supportive therapy? Who had it right? And one of the things I really found charming about that study was the emergence of the finding that one of the best predictors of outcome had nothing to do at all with the modality and had a lot to do with how you felt about your therapist. And it was one of those things that I had to chuckle and say, did we need research to demonstrate that? But it's always good to have research. I mean, that study found many other things too, but it was really one of my favorites to think about just the impact that clinical engagement, therapeutic alliance has for our clients. We know that good clinical engagement and alliance predicts symptom improvement session to session. We know that it predicts treatment attrition. So particularly in some of the SUD literature, we find that people stay in treatment longer when they have a good alliance with the clinician, when they really feel connected to the provider. We know that it predicts outcome measure performance. People tend to have better outcomes. They tend to have longer term outcomes when they are engaged clinically. We find that folks will be more prone to disclose difficult information. And I know I've read a few studies here and there that it includes relapse, that people are just going to be more likely to tell their therapist when they feel liked by their therapist, when they feel aligned with their therapist. Medication adherence improves in the context of therapeutic alliance, as does treatment adherence, and candor with non-adherence, which again, willingness to disclose. But we find that people are a bit more candid about what the research often calls undesirable behavior. So, someone engaged in interpersonal violence, if they broke the law, if they engaged in substance use and they were on a plan not to. These are the types of themes of, behaviors they might be more prone to disclose in a therapy session when they feel connected to that therapist. I will say that there is some mixed data on SUD outcomes. It is one of those areas where the finding still holds. I'd say that the longevity of the treatment outcomes doesn't hold as well as some others. So for example, I believe in the depression literature, we find that at 6 months post-treatment, clinical engagement is going to be a bigger predictive factor, a little bit less so for relapse prevention. That being said, I mean, I still feel the outcome data is very strong in SUD and indicia, that clinical engagement is incredibly important in this context. Great data on program adherence in SUD, and and just for your information, decreased probability of board complaints. I believe the American Psychological Association did some really interesting research some years back, looking at factors that led to board complaints and litigious action by clients toward providers, and noted that, among other things, rapport was a really important one, which is not to say that that's the only contributing factor, but it is among them. Okay, so what are those methods to promote engagement? Let's go back to first year clinical training. What do we learn as students are just basic things that will help clients feel connected to us. I mean, first and foremost, eye contact, making sure that clients, we're looking at clients, that they are looking at us, that they feel seen by us. Demonstrating empathy, really trying to reflect back the emotion that a client is showing to us. If they're crying and we're smiling broadly, it creates a bizarre interaction. We want to be mirroring, we want to be monitoring what's going on. Open discourse, that flow and that smooth interaction that really comes out when we have great rapport with our clients. It's one of those things, what's the quote? Well, I won't even try to replicate the quote, but I can't define open discourse, but I know it when I see it. I think many of us know, when we really feel in that flow, it is a very good feeling clinically. So we're taught active listening. We're taught to mirror affect. We're taught to mirror our body posture and to really show up physically in the space in a way that feels appropriate and feels respectful of what the client is going through. We're taught to be responsive and to, really notice what's going on with the client and ask questions. We're taught to be reliable, to make sure that we show up, and when we say we're going to show up, to do what we say we're going to do, and to be consistent. We're taught to be professional, to make sure that folks feel comfortable disclosing their sensitive information to us because they know we'll treat it with respect and that we will behave like medical professionals that we are. And of course, we're taught to reflect confidentiality, to make sure that folks know that information is private and that we are prioritizing their confidentiality and privacy above other themes. So, I mean, as you can imagine, where I'm going with this is there are some challenges that are unique to telemental health that really place a strain on clinical engagement, and I think have us working harder to connect to our clients clinically and build that rapport. I mean, the one that's so easy to pick on is eye contact. Eye contact is inherently disrupted in the milieu. We're going to see a lot of videos tonight of wacky eye contact changes, but it is one of those things that just makes video conferencing a little less connected, a little less human in some ways, because we're missing that really fundamental piece of what it is to interact. Body posture. When my client is disclosing something important, if they're in my in-person office, I lean in toward them. I want to show that I'm listening and that I care. If I lean way into my video conferencing screen, you'll be looking up my nose, and I don't want to do that. So, we have to be thoughtful about how do I bring body posture and how do I reflect some of these themes in a video conferencing milieu. And, we're not even touching on telephone, where these things are obviously just not options. In video conferencing, we're going to have less clarity on emotional expression in many circumstances. Video can pixelate, the quality can lag. We may not quite be matched up with the facial expression with when someone is speaking. We miss opportunities to inquire, secondary to someone's facial expression, how they're feeling. Technology challenges are real. Many of us, because of doing this work, are living this dream right now. The technology drags or lags, it drops. We have call interruptions. It may be that we are working with a product that is less reliable. And I have to say, week to week, the product that I think is most reliable changes, because many of these products, as I've discussed in prior classes, were never designed to handle the type of traffic that they now encounter. There may be questions about confidentiality and privacy when using these technologies that concern clients and make them remiss to share information. And there may be challenges to presenting ourselves in that usual professional way. One of the easiest examples I can think of is our office. When clients come into my office, I have designed it in a way that I feel promotes comfort, makes them know that it's confidential and private. It is warm and inviting, but it is also professional, somewhat austere. In my home office, that's more of a struggle. I don't have a home, with tons and tons of space where I can just have any office I choose. I've had to work with what I have in this current context. And, I think maintaining our professionalism in that context can be challenging. Not to mention if our children are banging on the doors. Okay, let's talk a little bit about your clinical environment. So when I say your clinical environment, I'm really referring to three distinct things: where you're sitting, where the client's sitting, and the thing that connects you, that technology environment that is connecting the two of you. And again, we have all of this research that talks about therapeutic alliance in telehealth. We know that therapeutic alliance and clinical engagement are such important themes to be successful in telehealth. We know that there is a lot of research on client satisfaction, time and again. There is really good data on clinical rapport, particularly over video conferencing, but there is some data for telephone as well. There's less data, and I'm not talking much about this, about the asynchronous modalities like texting and messaging, which I know a lot of the more popular primary care apps that have mental health included use. I just don't think that's as well studied yet. But so I don't really touch on that so much. But I think, for the video conferencing milieu and for the telephone milieu, we know that clients tend to like it. providers like it less. So this is, again, just a really consistent finding wherein clients tend to like it. And historically, they have cited reasons related to access. So again, these data came pre-COVID-19. So this research looked at people who wouldn't receive care otherwise, or maybe they had financial, barriers to care, or they had geographic barriers to care, they had mobility, physical health concerns, or childcare concerns. All of these reasons, folks might not be able to attend in-person appointments. Then all of a sudden they're getting telemental health care. Typically most clients were pretty pleased about that. Said, boy, this is great. I wouldn't have received it otherwise. Back when I used to be oversee telemental health at VA Puget Sound, I joked that our motto should be better than nothing, which is not the most inspiring motto, but I think says something. I will be really interested to see what the post COVID world looks like in terms of this research, because this has been so quickly democratized for so many people. People are receiving telemental health when maybe they didn't want it. So I am curious about how that that patient satisfaction data is going to hold up now that we have tons more people receiving telemental health. And frankly, some people may not have wanted this, but it was the only option in their jurisdiction or for their health or their provider's health. Again, pretty consistently, providers rate it lower. And, I could tell you I have diverse hypotheses on this. It's more work in some ways. Creating that clinical rapport is hard work. I'm not having to commute into my office, and there's some things I'm not having to do. They're time savers. But the reality is I think there's something almost performative about being on the telephone or video conferencing and really trying to make that connection at a distance. I think providers feel that. Additionally, I sort of joke, I went to school for a while, and to receive the message that they don't think I have to be in the same room with my clients was a hard pill to swallow. So I don't know. But, pretty consistently, patients rate it higher than providers. Still, there's relatively little research on environmental impacts. So to what extent, does making a really warm video conferencing environment help people feel rapport? To what extent does making sure you're addressing the gaze issue help people feel rapport? Do changes in our body posture or even our positioning in front of the camera help clients or help providers feel less fatigued? And I think that is a yet to be studied area, which again, I hope with this just being so much more widely disseminated, I hope perhaps someone on this call tonight wants to take on this research question, because I think it's a really important one. So, in absence of research, let's speak anecdotally. It is, I think, as important to accommodate the provider's needs as the client. And what I mean by that is it is really important to find a good, comfortable space for that client to be in. As we've spoken about in prior courses, we want to make sure that it's private, they cannot be overheard, that it is physically comfortable for them, that it has adequate lighting and so forth. But so too is it very important to make sure that provider environment is conducive to feeling comfortable and connecting. I think, when you're sitting in an uncomfortable chair jammed in a closet, it is just not conducive to, feeling connection with others. And I really want to acknowledge we're all doing the best we can. I mean, there's something so privileged about talking about, oh, we'll change our space and we'll, do this or that. We do the best we can with what we have. But I really do think the most we can maximize our comfort and our feeling as though this is a good environment in which we can deliver care will provide benefits to our clients. We know that clinical relationships vary as a function of comfort on both the part of provider and client, and I think this is no exception. So again, there are a few codified requirements in terms of what your environment has to look like beyond some of the things we've spoken about in previous classes. It must be private, it must be confidential. It is advised to be more austere without tons of busy information in the back that adds drag and bandwidth data to your call. But beyond that, it's not as though there is this specific checklist that people are given as to what their space has to look like or how to think about engaging the client. So let's dig into that a little bit. So again, let's think about your office. We've talked in prior classes about home offices versus professional offices. Professional offices, I think, are a little better equipped in some ways because we've already worked out some of these issues. We've already thought through soundproofing. We've already thought through appropriate lighting, acknowledging, though, the lighting we need for telehealth may be different than the lighting we need for in-person care. We've thought through themes such as client comfort. and art that is soft and mellow, and just a space that's uncluttered and professional looking. So some of these things have been solved for us in a professional office, but now we're thinking about it more and more in home offices as well. And again, some of us may be delivering telemental health from our work offices, some from our home offices, some from both. And again, today we're talking about not just the PHI management. In our prior classes, we've talked a fair bit about PHI management, but today we want to talk about the impacts of that environment on your client's connection to you. So again, if you wanted to really go on that deep dive, it would be the last class is number 3, but today we're going to do some refinements on this. So again, we're focusing on that home office, that individual office. I am not speaking so much today about environmental designs in clinics. There's a great article, Krupinski in 2014 wrote a really nice article about setting up clinical environments. If you're doing a medical environment telehealth program from one clinic to another clinic, how to set that room up. There's a really nice article you can take a look at. Okay. So let's talk about distractions. What does your space look like? How distracting is it? Is it austere? Is it cluttered? We want to, again, have something that looks professional, and that we've talked about previously. What we haven't talked so much about is when certain things start to look cold and clinical. We want it to look consistent with healthcare, of course. We don't want to be sitting in our bathrooms, but we also want the background to be relatable and accessible. It's funny, if you've attended this class previously, you've probably seen me sit in front of a very blank stretch of wall, and we'll sit there again today. And I have to say, I have received feedback from my clients over the last few weeks. They said, this is really cold. They said, this really seems like, I don't know where you are and I don't like it. And I thought a lot about that. I thought about, that in some ways was the intention, but for some clients it was unsettling. And I've been thinking more and more about something I knew to be true, which is we want an environment that feels comfortable and puts clients at ease. So, again, we want to think through what is visible in our space and, what are we disclosing? I made the joke in previous classes, if I'm sitting in my French villa and they're seeing, my many stables and rolling acres and, whatever else is happening in my fantasy life, would that disclose something about my socioeconomic status? If they see that there's toys everywhere, would they know that I'm a parent? If they saw a pride flag, would they make assumptions about my sexuality? If I had a political poster, would they know about my politics or just really my preferences and decor, what I'm like as a person in my personal life? And my appearance as well. I have mentioned in this class, I like to be a little bit more formal in my dress, than I am typically when folks come to see me. And I'm trying to kind of offset the informality of the milieu. Others will say, no, that feels cold. I wouldn't do it. We want to think about disclosure. And in previous classes, we've talked about this as a no-no, but today I want to go a little bit deeper and say there are some things that I think we could be disclosing and should be disclosing. I now have, in actually how I'm seeing my clients these days, they can see a chair, a chair that looks just like the chair that they would sit in my office. They'll see some pictures, but they can't make out what's in them. It has a more personal feel to it. They see a bureau, that's obviously a piece of wooden furniture that's a little bit more personal. Again, it has a warmer feel to it. These are sort of aesthetic non-specifics, but I think we want to think about what degree of formality feels right for your practice and the clients you serve. I have a colleague who works a great deal in court-mandated cases and has a specialty in treating folks who have borderline personality disorder, which one of the hallmarks of may be struggling with interpersonal boundaries. And for her, she said, no, I really don't want to disclose anything that doesn't feel good and that doesn't feel like the type of boundaries I'm helping my clients to create. I'm really helping them to shore up boundaries, and I want that to show up in my clinical work. I will share in my clinical practice, I tend to see folks who have anxiety, and the more at ease they feel in my clinical treatment room, the better we do. And so for me, that's the type of engagement I want to have, and that's what I'm trying to think about in creating my space. So again, we want to replicate our in-office feel. This is tough. We're going to do our best. This balance that we're finding between the professional and the personal. In thinking about this, we want to think about what population we serve and how are you usually as a clinician? As a clinician, I tend to rely heavily on levity. I make jokes with my clients Try not to make too many, but it is one way that I break the ice and I develop therapeutic alliance. And of course, not everyone does that. Who are you as a clinician, and how will that show up in your environment? If you're someone who really comes in and really presents, in a very professional, clinical sort of way, where you are the medical professional delivering care, that may lend itself to a very different clinical environment and feel that you're seeking to cultivate to deliver care than someone who is, doing, I think some of the hardest work folks are having to transition now, somatic therapies. I know some of my colleagues do somatic experiencing work, or work that has, really, they're putting hands on clients, they're touching people, they're, having these really intimate sort of physical interactions in boundaried, appropriate ways. So I think that, again, it's going to be a very different affect that they're communicating. And we want to think about how best to support, who you have been as a clinician, and continue to build this in your telemental health practice. Okay, so let's, not just talk about it, let's see it. Okay, so here we are in one potential spot for my clinical environment for my telehealth appointment. Now, if you've come to my prior classes, I'll beg your forgiveness. We've been here before. So I'm not going to stay too long, because I think it's pretty obvious to anyone who is looking, this is not quite right. There's a few things going on that I'd like to point out. One, our source of lighting. It's very bright and distracting. It makes me backlit, which makes me harder to see, changes the lighting when I move. Two, our angle is not good, so we'll need to change that angle somewhat. These are handy dandy stack of envelopes. Three, well, now that I'm a little bit more center, there's some pretty unprofessional things happening here. There's a bed, it's sort of messy. There is, this definitely that I'm in a bedroom, so it doesn't really necessarily have a very austere or personal feeling. You definitely get the sense I'm seeing you from my bedroom. So I think we know that we could do a bit better. So let's go over to another corner, and we're going to see what we think of that. And we're just going to keep making little iterations and improvements. Okay, here I am in another space in the same room. And again, if you've been to prior classes, this space should be familiar. It is austere. There's nothing in the background that discloses anything about my personal life. It is has very little data that it's requiring in the background, so it's going to use a reduced bandwidth for the video call. I've added a jacket, try to give myself a fancy look. I have made sure that I'm centered in my screen. There's a door visible, but I've ensured that that door is closed. And the light source now isn't sort of coming in and out. It's a little bit more steady and stable. So for all intents and purposes, this is a great, way that we could approach our telehealth appointment. I could back up a little bit so that you could see a little bit more of me. Clients could see me as I gesticulate, which has its pros and cons. And they would just get more of a sense of me if I put a little bit more of myself on the camera. But I want to acknowledge that we don't have to stop here. So I think this would be an absolutely adequate and perfectly appropriate way to see our clients. However, let's acknowledge that, different clients are going to have different responses to our space. Let's say, my in-person office is a space that is very comfortable. Let's say that, typically I have a squishy chair, and some fluffy pillows. I actually do have some fluffy pillows. They have very snazzy, bedazzled, tassels on them. It's a comfortable space. It has a feeling of being personable and warm, and yet still professional. And I have to say, a space like this is going to be much more austere, a little bit more cold and clinical. I'm wearing a jacket, which certainly is professional. But again, does that well match the type of clinical rapport I have, the type of, emotional sort of environment that I'm trying to create? And again, I want to acknowledge there is nothing wrong with this particular iteration in space, that we could see a telehealth client this way, and it would be absolutely appropriate. However, today's session is about clinical engagement. And we want to acknowledge that some of these environmental factors can impact how much therapeutic alliance our clients feel. For some, this feeling, this more austere feeling, a little bit more professional in its presentation, even though it's obviously a home office, it's just giving you less, I think is going to connote for some clients more comfort and just more of a feeling of a very straightforward interaction. For others, I want to acknowledge this could be a little too cold. I actually can tell you I received that feedback from a few clients saying, oh, I'm used to seeing you in a warmer, more inviting setting. So let's go to one last location in this room, take a look and see if we could try something else out and see what fits for us. Okay, here is our third location. So again, we're in the same room, but we're taking a different vantage point. Now, this is a much less austere background, and there are some notable disclosures available about my life, and let's think about this a little bit. So, now you'll note I have backed way up off my camera, so now my client can really see much more of me. They can see moments that I lean in. They can see moments that, I show distress or concern. They can see if I sit back. They can really observe more of the physicality. And for some people, that's helpful. Some people that helps connote something and connect to something. Additionally, they're going to see a little bit less of my face. So I think you can still see my face pretty well. But, in the other iterations, I was quite close to that camera. So smaller facial movements, smaller aspects of expression will get lost. But let's talk about what's in the background. We have a poster, from I believe the 1990s of a party I attended as a young lady. There is an area with some family photos on there. And this would start to, as well as a rather psychedelic picture behind me. There is a leather chair, sort of a masculine leather gentleman's chair. There's a bureau. So in these moments, I'm disclosing some things. I think if someone looked quite carefully, they could discern that some of these are family photos. So they might know that I have a family, perhaps could discern that I'm married. They would see sort of a quirky piece of art and maybe make some assumptions about what I think is funny or humorous. And again, I'd want to be thoughtful about what is my office like. I'll tell you, if you went to my office in Seattle, there's some quirky art in there. I don't have any family photos, but I do wear a wedding ring. So, I would be thoughtful about what aspects am I comfortable disclosing, what aspects am I not. And I want to be clear, I'm not suggesting that these are things we ought to disclose, but I'm also saying that, I think that it's okay to have some level of disclosure because in some instances it can create a warmer environment. And if that is who you are clinically, if that is what your clients need clinically, then being very thoughtful about boundaried disclosure and a little bit more casual sort of presentation in the telehealth environment, I think can help lend itself to folks feeling that same kind of warmth and connection that they experience in your in-person office. So again, 3 different views, 1 room, I was going to say none of them are wrong. The first one's wrong. But these latter 2, I think, give us an opportunity to think about how we want to show up clinically and what we think is going to help us have the most rapport with that client. And I will say again, the more austere the background, the less demand on the call. So if I started off with this background, but there was just, too many challenges to the internet, too many challenges to the quality of that call, I would probably fall back on that more austere background to see if it helped improve the quality of the call. Okay. So let's think also about other types of distractions. Particularly in home offices, noise are a thing. I know that my office, in my professional office, is soundproof. We actually have cloth panels that cover the ceiling and the walls. It really does a nice job of making sure that we have a quiet environment. We can speak softly. I can hear well. My clients can hear well. I tend to be soft-spoken, so I really appreciate that. Particularly if we are in our home environments, we are more subject to external noise at times, windows that are open, traffic, coming and going, noise in the home, children or pets, noise from our errant devices, our Alexas, our Siris. I will note also that a lot of us are using video conferencing software or telephone programs that have noise gates that will ostensibly filter out some of that background noise. One of the challenges I find is that it actually can filter out the smaller noises coming from us. When I've had clients sigh or a client make a small, yes or a no, and I can see their lips moving, but it doesn't come through on the audio. And that is often because the noise gate has caught it. It has perceived it to be a background noise and decided to keep that out, which again is a great feature in terms of keeping the quality of our calls good, but I think is challenging when we're trying to build rapport and really listen and hear what our clients are saying. Always when you freeze with your mouth open, that's the best video to have. Let's take a moment to think about the sound in your environment. Sometimes we take for granted that the sounds in our home may or may not distract, but I think as we look at it, we might find that some of the ambient noise to us, can in fact be very distracting to a therapy session. So, that can include the sounds that derive from our devices. It can include things like our text notifications, or maybe a phone ringing, perhaps a notification that comes from your computer or your email, perhaps a pet that's in the room with you, or perhaps other family members that need your attention. Yes, yelling mom. Some of these things may sound like the white noise of your life. However, I would encourage us to really think about the impact that has on our ability to be present and be heard. Throughout our entire time speaking for the last 30 seconds, my new puppy has been barking at us. I suspect it's very annoying, and I apologize to you, but I use this as an example to demonstrate these little things that may, to us feel like the usual things in our household can really diminish our ability to be present with others. And as always, get rid of those smart speakers and get rid of Siri because she is listening.
Sorry, I can't remove music from your library.
Yeah, okay, thanks. I could not have better asked the puppy to participate. She was pretty on cue. We, like many people, got a puppy in the current context. Okay, so let's talk about a vignette. Dr. Pepper. Today, our vignette doctors will be commercial product doctors. Dr. Pepper serves a rural population. She offers medication-assisted treatment for opiate addiction. She lives in an urban environment, and she works from her home office. She is someone who does have a professional office she could work from, but the commute is substantial. And in the current context, since she would be delivering telehealth services exclusively, she is contemplating doing this from her home office. So again, she might look to some of those appropriateness considerations that we've talked about in prior classes, but she also want to think through some of those themes that we haven't talked as much about, such as the disclosure of perceived differences. What is her home like? What is her life like? Does she feel comfortable sharing that? And how much of her personal life does she want to bring to the office and really have that intersection of work and personal? The themes I'm not talking about that we've talked about in other classes, of course, are how possible is that? Maybe Dr. Pepper has children at home, and leaving is not such a great idea. They tend to need watching those children. Someone needs to be at home. So there are going to be myriad factors that impact us. But today we're thinking about, what are the disclosures and how able is she to create a space that supports clinical engagement? So we've talked about the provider environment. Let's think a little bit about the client environment. So again, this is an analog of the environment that we're in and has relevance to appropriateness assessment, because when we're thinking about whether or not a client is a good fit for telemental health, we want to think also about whether or not they have a space that is conducive to them receiving care. And again, we have less capacity to dictate this, of course. We're not going to not see a client because their environment isn't perfect, of course not. And so too, we want to be respectful that it is a privilege to have a private space. So we want to be really thoughtful about what we're asking of clients, but as much as we can, support clients to work with what they have and create an environment that will allow them to be comfortable and connected. So again, these are themes like privacy, making sure that there are limited interruptions, and making sure that it's conducive to a healthcare environment, a healthcare appointment. As I've mentioned in prior classes, we can help clients if they have other demands in the household by scheduling breaks so they can check on things, so they're not having quite so many interruptions, thinking about alternate ways of scheduling. Do they need earlier appointments or later appointments? Are they coordinating with someone else in the home? And making sure that we are balancing themes of having a professional environment with making sure our clients are comfortable.
Hi, Sarah. Thank you for joining our session today.
Hi, Dr. Jason. How are you?
Very good. Are you alone and in a place where you have adequate privacy?
Sure am. I'm in my bedroom today.
Oh, fantastic. Huh.
Does that work for you? Is that good?
Well, things seem a little bit wobbly.
Oh.
Is there a way that you could put your device somewhere where it's a little bit more stable?
Yeah, I have a desk over here. Why don't I just go to the desk? I'll be right back with you.
That'd be fabulous.
Okay, hold on one sec. Okay, Dr. B, I'm in the laundry room now. I guess, is that a little better?
Well, I noticed that you're standing, and I'm worried that that's not going to be very comfortable for you long term.
No, yeah, I think I was just thinking about a private space that had good lighting, and that's what I ended up choosing. So I thought this would be the right place to be. Plus, I can do, the laundry while I'm here.
Yeah. So that's probably not going to help our communication, so that we can get you the best conversation.
Maybe private, quiet, and well lit without, too much wobbling.
I think that's a really good idea.
All right. I got just the thing. Hold on. Okay, Dr. B, how about that?
Well, the lighting looks good. I can see you. The picture is stable, and so that works well. Are you comfortable there?
Yes, I'm sitting in the bathroom on the mat, but the door's closed and I know my kids won't come in here.
Well, if this works for you and it's comfortable for you, I think this will work just fine.
Okay, let's do it. I don't know about you guys, but I have had quite a few sessions in bathrooms of late. And, I actually chose the bathroom to be the final one that works because I've thrown out a lot of my predisposed notions. I'm looking for a place that is private and that is comfortable for my client. And I don't just mean physically comfortable, although I also mean that, but I mean comfortable in terms of they feel that they're not going to be overheard, they feel they're not going to be interrupted, and they feel like this is an environment that they can connect in. So I try not to be too prejudiced about closets and bathrooms. We had a question last class, which I thought was a great question, which was about the car. I have in some circumstances delivered care to people on their mobile device in their car. Again, we want to think about where the car is parked, whether or not they're worried about being seen by neighbors, some of these confidentiality and privacy concerns. But if that's the best option for them and they have a private vehicle, maybe that's what needs to happen to deliver them good care. It's not my preference, and in another time, 6 months ago, my goodness, this would have been a very different conversation in which I would have thought, well, just have them come to the office, of course. But now, if this is the way that they get the care they need in a way that they are comfortable, I'm going to be flexible. Okay, that technology environment that connects your space to the client's space. So again, some of the themes we've spoken about, like internet stability, the connection quality, dropped calls. We've talked about the importance of having redundancy, more than one video conferencing software that you work with, or the option of a telephone service, making sure you have their telephone number on hand if that fails. Thinking about backups. I like to, have additional sources of internet. I often will tether to my mobile device. And again, I'm going quickly. This is in prior classes. But, these are ways in which we're making sure that the calls don't get too interrupted. I'll be honest, if I start a call and the video call quality is just poor on one platform, I almost immediately will hop to another platform. It is a pain in the tush. And I hate to take up session time to do it, but if I just know that this is going to impair my ability to feel connected to the client and their ability to feel connected to me, and I know that the other platform offers an alternative, I'm going to make the suggestion and do it very quickly. I want to, put a pause there and acknowledge that I tend to have clients that are pretty darn tech savvy. Some of my clients here and there, it's been a struggle for them to get on that video call. And for that client, I would never do that. They got there, that's wonderful. I wouldn't add the stress of asking them to hop over to another platform. If, however, there's someone who's on, this video call and that video call routinely, and this is something quite easy for them, they have a lot of facility, then, I would probably pretty quickly tap into my redundancy plan and try to find the best option that I could for, feeling connected. Again, we want to choose video conferencing programs that have technology features that lend themselves to rapport. So something that's really easy to use, has good customer support. Again, I always encourage you to do a test call in advance of that first intake. And again, we talk about themes like intakes in prior classes. Because I think there's this opportunity to sort of do a test run and answer any questions they might have, get them a little more used to the modality. If someone shows up at the appointment and they're so frustrated with having really struggled to get connected to you, it's not a great start in terms of your clinical engagement and rapport. They're coming to you having already been through the ringer, and it makes for a harder start to the session. I like the option of having a self view so you can see what the client sees. It also gives you an opportunity to see what your face looks like. When I ran a postdoctoral program in telehealth, I used to record all the postdocs, just have them record themselves on their phone first day to really get a sense of what they look like when they spoke on video. And these warm, lovely people who interpersonally in the same room just couldn't have been nicer, kinder. When we watched a video of them, they looked stone cold. They really looked, like they were not emoting. And we realized how much they may have leaned into certain tricks of interpersonal communication, like body language, or like just these small non-specifics that were not available to them in the video conferencing milieu, and certainly not available over telephone. So I think there's this opportunity, to make sure we choose a technology product that shows us what the client is seeing, and that we can configure it in such a way that that's not distracting. We want to focus on the content of our discourse and not the technology. And we want to be thoughtful about our angles, which is a silly seeming thing, but a slight difference in our angle can actually create a very different feeling in the session. Oh, where's well, we're going to pause here. Forgive me, my video is out of sync here. We're going to pause here and just try to answer some questions, and then we'll keep going.
Well, Sarah, we only got one question so far, but now that you paused, some people might enter some more in the chat box. So with that, early on, Tom said, I'm concerned about confidentiality of breakout rooms in Zoom where clients in a group share information and exercise. Can you provide best practices for this format?
Yes, I think that's a great question. It's something we, I think, spoke a little bit about in the last class. So I would encourage you to take a look there, but I'm happy to speak about it now as well. I think when we do groups over telehealth, there's wonderful opportunities through this milieu. I always share, I have a colleague who does OCD and hoarding groups over telehealth, and it's just this wonderful opportunity for clients to receive support in the home, and for other group members who've been there, who understand what they're going through, and they can actually do discarding together. That seems so important as part of their exposure and response prevention. However, I think that when we enter into multiple, anytime you have a group, period, you have multiple players now in privacy and confidentiality, and that's more risks to privacy and confidentiality. Add on top of that now you're in these folks' homes. And I've certainly heard it happen where someone has had a spouse, walk through the background, or, something. I think, especially if you're using some of the breakout rooms, actually, irrespective of how you configure it, I think there's just this element of, greater risk. So the way I'll say the way I handle it is I really hit this theme hard in informed consent, and talk to folks about the importance of safeguarding not only their privacy and confidentiality, but that of their clients as well. And I really spend that first session talking about themes of environment, making sure that, no spouses in bathrobes. The bathrobes is the best case scenario, are walking by casually, into the view, because that is not only embarrassing and a problem, for the client's privacy and confidentiality, but now you've also impaired the privacy and confidentiality of the group members. So I really I spend a fair bit of time talking about what it is to be a good steward of the group's privacy and confidentiality, and really what that looks like very specifically in terms of environmental configuration and behavior.
Okay, here's a little different pivot, but I got a question from Renee. She's curious about what type of equipment is needed for starting a telehealth practice from home.
Great question. Pretty minimal, to be honest. I mean, I think most laptops these days have embedded cameras. Not all, but many, many do. So basically you need a computer and you need a camera, and you need some sort of telephony, some sort of a phone for calling people. And I would encourage you to invest in a product for healthcare for video conferencing. I will say that many people like to in addition, have some sort of product for exchanging documents, like a secure email or secure message program. If you have an electronic medical record, this can be one-stop shopping, wherein they'll give you a video conferencing product, a way to communicate with clients, a way to schedule appointments, a way to process payments. I am a lazy woman in my heart, so I rather like that because it's just one product I need to contend with. That being said, I do think there is value in having redundancy, so having more than one video conferencing platform you work with, because some days they do go a little funky. And then finally, finding that space that is private and confidential, not the middle of our kitchens where people are coming and going and getting toast to deliver that care.
Okay, thank you. A question from Daniel. What do you think about green screens? They can seem kind of cold.
Yes, I'm not a fan. I respect that may be the best option. Because it may be, that they just don't, the clinician doesn't have a space, that otherwise would be appropriate and not make too much disclosure. But I'm not a fan because I do think they introduce additional drag on the bandwidth. And I find that they clip people's heads off, that you miss things. In fact, there's something about my eyes that green screens do not like. So whatever the background is, it will show up around me and inside my eyes, giving me a very demon-like appearance. Something about it doesn't like me. So I think, I'm not the biggest fan. I actually like the green screens just plain, and at that point, just buy a sheet and hang it up. And I've certainly had some colleagues who they tack up a background that is just like a white sheet or something like that to try to give a more austere appearance. I think that can easily look a little frightening, but if you can do it in a way that doesn't, look too janky, I think it's okay. But I'm not the biggest fan of green screens, just because I don't think the gadgetry of it lends itself to that feeling of rapport and connection. That being said, my colleague who I do other webinars with has a beautiful one where it just looks like she has the most beautiful office in the world. And so I don't know, maybe it's a good thing, but it's not my favorite.
Thank you, Sarah. Hey, this was a little bit of a long way to get there, and it has a couple of questions in it, but I'm going to just read what Kimberly wrote.
Sure.
She said, I've noticed the increased fatigue sometimes during telehealth, working harder to get all the available client nonverbal info that would be easy to get in person.
Yes.
Does it get easier over time? And is this acclimating to having less nonverbal info or getting better at client nonverbal info in a different way?
I think that's such a great question. I do think it gets easier over time, although I think that, David, as you and I were talking about earlier, self-care is going to be really important. I was sharing that I used to see 9, 10 clients in a day. I can't do that, over video. I just can't. It's just, I get too worn out. It doesn't energize me in the same way that in-person care does. I think that, you are making, your behavioral observations are more limited. And again, last class we did a deep dive on this, but we just have fewer opportunities to catch that minutia of someone leaning in and tapping a toe or picking a cuticle, and we're really having to change. I find myself just asking tons of questions. I'm asking what this means, what that means. And, I talk to my client about how that feels. Does that feel invasive? Is it helpful? But I really cannot make the same set of assumptions. The example I think I used last time is if I see a client that is looking down, or staring off into the distance, if they're in my in-person office, I would assume they're feeling something. Maybe they're avoiding, maybe they're upset, maybe they're bored. I would assume something about that emotionally. Now I'm wondering, are they looking at their email at another screen? Are they checking their phone? Is there something going on in the room that I can't see? I think it's just a wider set of concerns, and I just don't see any way around it other than asking lots of questions.
I'm going to read this one from Carol, then I'm going to get back to Brian because this one fits really well. How do you handle a situation when a client in the group lays down, smokes, or wants to eat during the discussion with the entire group?
That's a great question. So I think in a group milieu, I might handle it differently than one-on-one. One-on-one, I think I would just gently but straightforwardly ask, why are you doing that? Mm-hmm. If it was in a group milieu, I'd have to make a decision as to whether or not, calling this person out disrupts the group flow too much. I'd have to question how much the behavior, is disrupting the group versus what it's going to be like to talk to this person about it. I think I just would want to know. I'd want to know, why is it really important that they do this at this moment? I would try not to come making suppositions. Maybe they're starving because they haven't had a chance to eat. Maybe, they're trying to quit smoking and, maybe it's a clinical issue. Maybe it's not a clinical issue. I would say, though, that I would strongly encourage them not to be doing behaviors like that, because it does not lend itself to the same type of presentation that they would show in my office. They're not going to come into my office and smoke and eat. I mean, if they're starving, they can eat, of course. But, I think to me that starts to blur boundaries and start to feel less like a healthcare appointment, more like a friendly chat, and that I don't like. But again, I try to be gentle about it and ask questions and ask why this is important and communicate that I think it's important that we keep those same boundaries as in-person appointments without being shaming or scolding in any way. But again, if it was in a group, I'd have to think about whether or not I addressed it in real time or I addressed it with that person after the session and started the next group saying, hey, we're not going to do this. I think that'd be a real-time call for the excellent clinician.
Yeah, it's almost like you're saying is like the group norms don't go away during telehealth.
Right. Yeah, it's exactly right. It's the same.
Okay. Question from Brian. Is there anything you do in your telehealth practice to re-engage clients that have fallen out of touch?
Meaning that they're no longer coming in?
I think that's what the question is, that they're losing contact with them.
Yes. I mean, I think I've had this happen probably once or twice in the post-COVID world. I pause and I think about what I know about them. Were we in the middle of termination? Were we just getting started? Are they someone who I regard as, being at high risk in any way, or not? I think that these would be factors for me. I do make a telephone call, and I try to, in that telephone call, communicate that I'm just calling to check in, and, that it is not to try to talk them into coming in for a session. That's not my goal, unless I think that they're at some sort of risk. And I do think that's, clinically indicated, and I'll share that opinion. But most often I'm calling, I'm checking in. I just want to know how they are, and if indeed this isn't right for them or there's a concern, about the modality, I just want to talk about it. I think we talked about this last time a little bit. When is it clinical avoidance? And when do they just not like the modality? Both are really valid. But if it's clinical avoidance, I want us to work through it. I want to talk about how we can engage, and I want to talk about how we can make this work. If it's just not their preference, of course, people have the right to determine how they receive their care. And I think it's very hard to say at times. But I usually make a telephone call and check in, just see how they're doing, communicate that I'm not seeking to recruit them into sessions as much as I want to know if they need care. And if they do, I want to think about, how we can best give them that care.
Thank you, Sarah. So that was about 12 minutes of questions. More, or what do you think?
Well, why don't we hold forth for a little bit more, and then we'll have some more question and answer period later on. But we're about a little more than halfway through our slides and a little more than halfway through our time. So, why don't we talk about those behavioral factors, and then we'll have another Q&A time.
Okay, all yours.
All right. Okay. So again, our clinician physical presence, these behavioral factors, that we were trained to do, trained to make eye contact with people, trained to position our bodies in certain ways. I think in the video conferencing milieu, a lot of times we're having to choose between face or body, because if I'm really close to the camera, you can see my face quite clearly. If I'm farther away, you see my emotional expression with less acuity, but you're going to see more of my physical posture. And hands. I am a terrible hand talker. And so I can say sometimes it's effective, sometimes it's kind of engaging, and sometimes it's totally distracting and strange in video conferencing. Thinking about your self-view, who you are on camera, and what best suits your clinical style. I really can't say this enough. Record yourself, watch yourself in the self-view, see how you show up, and what do you think of that? Let's talk about body, gaze, and hands. These are, small ways that in our in-person sessions, we help build therapeutic alliance. We look our client in the eyes. We reflect and mirror their physical posture with our own. Perhaps if you're like me, you're a hands talker. We use our hands to help communicate and emphasize points that we are making. These aspects of rapport and alliance are impoverished somewhat in the telehealth modality. So we want to be thoughtful about how we're going to bring to life, these important aspects of clinical engagement through the distance milieu. So as I mentioned earlier, gaze is, one that's often talked about, and it is the case that when I'm looking at where my client appears on the screen, I'm looking downward. And when I look up toward the camera, I'm giving the appearance more of looking someone straight in the eye. Of course, the challenge of this is that if I stared in the camera for the entire session, I would miss what my client was actually doing. So I want to talk a little bit about different options we have around this. I've jokingly said I'd like to train my eyes like the chameleons from Madagascar, to have one eye up and one eye down, which I'm sure would be more disconcerting than what I'm currently doing. I think for many of us, we mostly are looking at where the client is on the screen. It is my recommendation every once in a while, and it's a strange habit to get into, look up at the camera. I think it gives the impression of, looking more closely. It's a funny thing, but play with it a little bit. And in all of these instances, I'm going to really recommend that you record yourself. There is no proxy for it. It is a significant difference to sit and have a conversation with someone like this, which is a perfectly reasonable thing to do in person, versus to have a little bit more engagement in our face, in our body, and with our hands. In person, this is felt with less, with less intensity. I think it's a less prominent aspect. However, when we do it in the telehealth modality, maybe a perfectly reasonable way to be interacting with one another in person, but it comes across as more flat and connotes less emotion to the client. So I think there's this opportunity for us to record ourselves. I've had the chance to do this work with lots of folks, and people are genuinely surprised about the discrepancy between the emotion they're intending to communicate and what they actually are communicating. So I want to really encourage you, set up your mobile device, set up your laptop, likely has a recording function, and give yourself a little bit of a chance. To see exactly what your client is going to see, in terms of your posture, in terms of your facial expressions, in terms of where your hands go. I will tell you that I'm a hands talker, and it's a challenge. It actually can be quite distracting. So at times during a therapy session, I will have to hold a pen because it's the only way I can really stop myself. But I think in doing this, we get to know ourselves a little bit better, and we get to make some decisions about how we want to show up in this modality. I recall taking a training many years ago that said, you want to demonstrate 110% of your usual facial expression and emotion. I'm not sure quite how we quantify that, but I think there's something to it. Our usual facial expression is well served to be a bit more pronounced. We're relying more on our face. So if we can, as we watch that recording, decide how much we want to turn it up versus turn it down and practice that, it's going to give you an opportunity to sort of make sure that you're doing all you can to create an environment that is conducive to rapport, engagement, and connection with your client. Okay. I want to acknowledge some specific challenges for folks who do somatic therapies, any therapy in which there is body work involved or any sort of physical contact. I think that for some of the clinics I've worked with who've done this, they've actually considered establishing, clinic-to-clinic practices, wherein there's two clinicians, one, working, having contact with the client, one not, counseling and advising what type of contact to have. I think, into home offices, this gets just a lot more challenging. But, I think we're trying to be thoughtful about how we can transition this. Some things really lend themselves and some things less so. So we want to think about what space is available to our client, and particularly if we have more than one client joining the call, this gets especially relevant. What number of devices does the client have available? I think that this really speaks a lot to privilege, that there is, some folks are going to have multiple computers or multiple mobile devices, or they're able to have people joining from different devices on a single call, a single family call perhaps, or someone joining as a collateral reporter, couples therapy, or parent and child interactions. I think that we got to work with what we have and make sure that we are thinking about what the client needs. And again, there are going to be some pros and cons to doing it different ways. And I'd like to show you in a video context what I mean. So let's speak for a moment about angles. Right now, I am using a laptop computer that has a built-in camera embedded right at the top of the screen. And I actually, for most of this series, have recorded all of my videos using this type of camera. The reason I do this is severalfold. One, I think this is what most folks are going to have. They're going to have some sort of device with a camera built into the screen right at the top, most often a laptop. And two, if I'm honest, I rather like using this. I think it is pretty close to where my gaze would be, and I feel like it minimizes some of the gaze discrepancies that happen, as we reviewed a little earlier in today's class. However, there are a lot of other options, and I'd like you to take a look at a few other formats, not just for one person, but for several. We're going to talk about our angles. Gotta hit them angles. Okay, so one thing I want us to note is our light sources. I've intentionally chosen an area that has me backlit and side lit a little bit, and I want you to note that with this camera angle and this positioning, you're probably going to see some light fluctuation coming in and out. I don't know that it would be a deal breaker for a video conferencing session, but it's not my favorite. If I was going to remain in this angle, I would likely make some adjustments to attenuate that. Most likely I would do that by closing my blinds, by rearranging my curtains a little bit, perhaps bringing in a lamp to stabilize that light. However, I'd like to show you how different it might look just by changing the camera angle alone. So hold on one moment. Stay right there. Okay, now I am using a camera that's a little bit at a different angle. I happen to have several cameras in my office here. I'm actually in exactly the same spot as I was. And one thing I want you to note is how different the gaze looks. I'm slightly off center from the camera. And note how different that looks. Now I'm going to move my chair just a tiny bit. And it's probably going to give it a much more normal and natural appearance. However, the ironic thing is there's an inversion when we really get these very top-mounted cameras. So right now I am using a USB-supported camera that is mounted several inches, about a good 6 inches, above my screen of a larger desktop computer. It's a different option. Many people like it because it gives us a little bit better resolution. But the thing I'll note is I think the gaze issue is even more discrepant, a little more weird, if you will. I think our light has been nicely stabilized to a certain extent. We're capturing a little bit more, so we're capturing a little bit of that glow. But as you can see, you're not having those fluctuations in and out. So some people do like this type of camera environment more because it tends to be a little bit higher quality, tends to have a little bit more normalization of some of the light issues, tends to come at from a higher angle and capture a wider swath of the screen, swath of the room for your screen. But as you can see, I think it accentuates the gaze stuff. Now, I guess if I looked dead center on my screen, it's a little bit better, but it's a hard thing to train oneself to do. So I find that when I use my laptop camera, versus one of these cameras that's mounted on top of a desktop computer, I see less discrepancy in the gaze issues. Okay, now we've been talking about one person, but a lot of questions, great questions that I've received in the last few weeks have had to do with couples, families, groups. How do we think about it when it's more than one person? Let's take a look at some of the options. Okay, so let's have a family session. Here we all together. Some of our family members are more discontented than others, but here, when we're all together, we can see one another. You can see the family strife and interaction. This one just bit that one. This one's kind of naughty. Yes, wonderful.
And this one is very bookwormish.
That one is very bookwormish. We can see those small moments together when people look at each other or look at another family member. We can see how the group interacts when one is speaking versus another. We can really get a sense more of what's going on in between the members of this group. However, we're also losing a fair bit. We're pretty far away from the screen right now. We can't mute the noisier members. And I think you're gonna lose a lot in capturing what's going on with people's faces and those more nuanced interactions that folks have. Okay, so let's take a look at the option for another format. Yes, and let's put our angriest member in a carrier.
I brought it up.
So here we are in a different video environment. The same family, but now each in our respective offices. And you'll note that we are
you are better able to see our facial expressions. So if one of us says something and the other has a response, you're going to see that with greater acuity. What you're losing, however, are those small minutiae, those interactions that occur interpersonally when we're all together. So when I say something ridiculous and one member of my family looks at the other member of the family, you're not going to catch that in this, right? Yeah, this doesn't work. You're not going to catch that in this configuration. So it's something to think about when you're deciding, do you want people all in one space or joining from separate devices or even separate locations? Now, of course, sometimes the situation's the boss. And if people are in separate locations, we will do it this way. This is particularly salient as we are enacting quarantine. And of course, I'll put a plug in as a reminder, always be thoughtful of your jurisdiction and make sure that all therapy participants are within your licensure jurisdiction.
So let's think a little bit about boundaries, how we can help support boundaries that support clinical engagement. So we've spoken in prior classes about establishing expectations, that initial phone call to make sure that we think we're the right clinician for telemental health care, perhaps a test call over video conferencing to make sure that this feels good, this is the right modality, that informed consent process in which we review the risks and benefits of the modality, talk about emergency planning, and so forth. The first session and each session, I feel like we're helping folks to understand those boundaries and expectations. And why are we talking about this in the context of clinical engagement? I really feel like, that the more we help our clients to feel kind of held by the environment, to understand what the expectations are, to in some ways have it mirror that in-person care and rapport that perhaps they're acclimated to, the more we set ourselves up to succeed, to really engage with our clients in a way that feels familiar and comfortable. We want to make sure they have a private, confidential space, we and they, that we are being honest, with one another about when it's difficult or what we do and don't like, and that we're treating this like a healthcare appointment. I think in these ways, again, we're setting ourselves up to succeed, and we're helping benchmark expectations that really lend themselves to candor and connection. I want to say a word about kids and pets. It's hard is what I want to say. Many of us, like myself, have kiddos in the home, and it's wonderful in a lot of ways and really hard in other ways. It is so challenging as we are trying to parent and perhaps homeschool, to be thoughtful about how to keep that environment appropriate and kid-free. So, I think helping folks think through what those challenges are in advance. I have that actually as part of the informed consent process and thinking it through myself. I also will acknowledge that many people find that having their pets in the room is better than not. And again, I'm actually more permissive about that. I don't have a problem with pets in the room, provided it's not noisy and distracting. I wouldn't have my puppy in the room because my puppy is naughty and barks and bites regularly. However, I joke that cats are video stars and will not be denied access to a telemental health room, nor strutting in front of the camera. The dogs you don't see, the cats you see a lot of. So, really figuring out what works well. And actually, even for the clinicians, if having the cat in the room is what makes the cat not howl at the door for the entire hour, then perhaps that's the thing to do to help keep the focus on the engagement and the rapport. Plus, it's humanizing. Having a pet is humanizing. Vignette, Dr. Bronner. Dr. Bronner is treating a client for polysubstance use disorder and comorbid dysthymic depression. Dr. Bronner's client has a history of complex trauma and struggles to find a private space in his home. Dr. Bronner's client wants to use a non-HIPAA compliant platform, so he wants to use Zoom, let's say, but not the HIPAA compliant one. And we know, if you've gone to prior classes, the U.S. Department of Health and Human Services did make an announcement several months ago that clinicians are now allowed to use these non-public facing video conferencing products, your Skypes, your FaceTimes, your Zooms. Technically, we can use those now to deliver client care. It's always my counsel that we still prioritize using products designed for healthcare, but it is a valid option, one that Dr. Bronner's client wants to use. So, for Dr. Bronner, I would be thinking about what are the jurisdictional considerations? What does his jurisdiction say? We have this federal executive order that says we can use these other products, and that would support what the client wants to do. But what does it say within Dr. Bronner's jurisdiction? Because if Dr. Bronner gets a board complaint, it's not going to come federally. It's going to come from that state board. So I'd want to know what how the state board has opined. I would be thoughtful about what my perception of the safety of the situation was. Is the client proposing that we use Facebook Live or Instagram TV, or, put something in the public forum, which is obviously inappropriate, or is it something still one of those non-public facing products? I would want to know why. So if my client is just a technologist and they believe in the product and they think the call quality is better, honestly, I would think about it, which is not to say that I think everyone should. I have colleagues who absolutely wouldn't. I have colleagues who say, no, I am the one who is the covered entity by HIPAA. I'm going to follow the rules. And I really respect and appreciate that position. I think for me, I would want to know why. And the reason I would want to know why is I would be thinking about clinical rapport. Is my client just more comfortable in Zoom than they are in simple practice? Do they prefer FaceTime and they don't like VC or VidYO, those healthcare products? And with cause. Honestly, the non-public facing products for business tend to be nicer. They tend to have more features. I think they tend to be a little less buggy than some of the healthcare products. I know I probably shouldn't say that, but I do think it's true. I'd want to know why. If it really felt that this was going to aid in rapport, but did not have specific clinical relevance. And what I mean by that is I've had consultations with folks whose clients have concerns about recordings and privacy and, which are valid concerns, but for them, it's linked to delusions and ideas of reference and a delusional process in which they're being persecuted by government entities, for example. Then I'm starting to be reluctant to change the platform. Am I participating in a delusion, and could that hurt my client? So I'd want to really understand why. Do I think it has clinical relevance, and do I think it would support rapport? Okay, so let's pause again and maybe do some more of those questions. David, sounds like we had a few, and I'd love to hear them.
Wonderful. So I'm gonna back up a little bit to the questions from before, and if anybody has anything, please use the chat box, and I'll get to those in a minute. So Bobby, who is a substance use disorder provider, wanted to know about monitoring urinalysis if a client is court ordered.
Mm-hmm. This is a great question, and it's something we've talked about in prior classes. So I'd encourage you. I think it was class 3 that we talked about this. If you want a longer answer, but I'll give you a short one right now. It's hard, right? Monitoring UAs. I think that I feel very reluctant to ever advise someone to do an observed UA because with the clinic I've worked at, there were observed UAs where same-gendered staff or same-gender identifying staff would observe UAs. I'll be honest, I didn't love it. I thought it was invasive of the client's privacy. I understand that there were reasons that they did that met court mandates, met reporting mandates. Generally speaking, we can, of course, get remote urinalysis. There are home tests we can do. We can have people drop off a sample. There are ways around this in a telemental health milieu that involves somebody dropping off a sample at a lab or, even using a home test. I think that where it gets sticky for me is this idea of observed UAs, and which I think was the specific question, which we actually observe someone give the sample. That starts to get into boundary crossing that I feel very uncomfortable in the telehealth milieu. And not even that I would ever second guess the intent of the clinician as much as I feel like we really risk having folks feel very uncomfortable. We risk pushing boundaries in a way that I think I wouldn't advise it. That being said, I know folks who do it, so I don't want to say that it's not, that no one's doing this. Some folks do. But my general rule is I would rather have folks either, if they need an observed UA, do an observed UA at a remote clinic and collaborate in that way, or do a home test, and I'll just believe their self-report.
Tyron wrote in the box about some of the ways that they deal with it. Another question is from Mary. They had one of their clients take a picture of the group as a way to prove their attendance. Any thoughts about how to avoid this in the future?
Yeah, I will say that most healthcare products will not allow recording to be initiated by clients, but of course they could do a screen grab. Anybody can do a screen grab. And that is the type of thing that that's very hard to police. because it's not as if you can go and disable the screen grab function on everybody's computer, prior to having a video conferencing appointment. That is really where we're just trusting people to be on good behavior. So my tendency would be that's like an informed consent issue, and that's the type of thing I definitely talk with a client about, because that's not up to them whether they share the PHI. And to be clear, a photographic image of a client is definitely PHI, ePHI in this case, because being transmitted electronically. But I think it's definitely the type of thing where I would revisit those group norms.
Cool. Lana had a question. In her group sessions, some of the clients have difficult times expressing a lot of emotions, and they go off screen to express them. Any suggestions about handling that?
So they're actually disabling their camera when they're talking about hard things?
Yeah, it sounds like turn off their video, or when they're showing emotion.
That's what my daughter does in online school when she wants to read a book. But yeah, I mean, forgive me, I don't mean to make light. I think I have mixed reactions to that. On one hand, I want to respect the client's autonomy and their right to contact regulation. And if that helps them, disclose, there's part of me that wants to support that over time. So I guess I would never explicitly shame a client or say, you can't do that, but I would want to ask questions about why that felt important for them and how that helped them feel safe. And to be transparent, I would definitely have a clinical goal over time to help them feel safe with that camera on. What type of rapport and engagement, is going to help them feel that they can say what they need to be said and really be seen by other people. Because I think that's some of the magic of a group, is that we are sharing difficult portions of our lives and vulnerable emotions in the context of other human beings, and having them observe that and join with us and allowing that emotional experience to happen. That being said, that's not where everybody starts on day one, to be certain. And I guess if that makes the client feel comfortable, I'd be okay with it for a while, but I'd really want to understand it. And I'd probably be pretty explicit that I had a goal over time for that to happen less.
Okay. Thank you, Sarah. Here's a question from Danielle. The client, they're trying to get a client in a location where it's a little bit more private, but the client is kind of willing to go to a place where they're overheard by other people and they don't really care.
Yes, I've had that conversation a lot with folks. I think I appreciate that concepts of privacy and confidentiality are changing, and some might say evolving. I'm going to say changing because I'm old. But I think that there is a practical reality wherein I feel like generations below me have very different relationships with this, secondary to lots of reasons. They participate in social media. They put more of their lives online than perhaps I do. And I appreciate that. And perhaps over time, as they are the ones who become the clinicians and write the policies, we'll see an evolution in our own thinking and our own policies. And today I'm covered by HIPAA, and today I actually have a requirement legally to protect their confidentiality and their privacy. And I try to approach this from two ways. One, I talk about my legal obligations to them and I ask for their partnership in that. And two, I just share anecdotally, I've done this long enough that sometimes folks think they're not going to be, that they don't necessarily anticipate the ways in which this gets hairy. They think it's totally fine and great and not a worry at all until they're, the girl that they really want to date walks into Starbucks, and sits down and starts talking to them and they're on a therapy session, or when somebody comes up and says, hey, great to see you at that, Rager party yesterday, but they're in SUD treatment. Now they're going to have to explain that. There's too few boundaries around disclosure, and it doesn't protect them. And so I ask for their trust as I share with them the manner in which I've seen it go wrong for people. And, folks think they won't care, but situations arise. And I've seen enough of them to really want to do it this other way, in a way that really safeguards their privacy and confidentiality.
Thank you, Sarah. Good explanation. A question from Tom. Are there different best telehealth practices for different ASAM levels of care, like early intervention, outpatient, intensive outpatient?
That's a great question. I would refer, and my honest answer is I don't know. I think that, I know there are different levels of care, but as it relates to telehealth specifically,
Right.
I am not familiar with any gradation like that. I would refer them to the SAMHSA guidelines for having video conferencing appointments. You can find it on samhsa.gov. They actually have it pretty prominent, pretty close to the landing page these days among their COVID resources. the way I think about it is telemental health is not a clinical specialty. It's really about bringing the great clinical skills that you have already, to clients using the technology. So it is rare that you will see that much deviation from treatment protocols and manuals secondary to the telehealth modality. Sometimes there's a practical necessity, like in prolonged exposure, I sit so close to people, my knees are practically touching them. Not in telemental health. There are some things that are just, they must adapt. But I have rarely seen, I'm going to say this and I'm going to tell you the one time I think there's an exception. I've rarely seen a ton of change to the recommended intervention itself because of the modality. The one exception I will say is particularly salient with pediatric clients, as I have seen people addressing this issue of Zoom fatigue, and struggle with particularly younger folks maintaining their attention. I have seen some recommendations to abbreviate sessions, and that could result in more sessions. So I could imagine a circumstance in which that is salient, but it wouldn't be specific to a diagnosis or level of intervention.
Okay. One more.
Sure.
Kurt asked, how do you deal with clients with a sudden expression of self-harm?
Great question. Excuse me. And I believe our next class is going to do a really deep dive on this. I start from the place that, again, 6 months ago, this would be a really different, conversation. 6 months ago, I'd say, come into my in-person office. I want to talk to them. Now that may not be an option. So that depends on your jurisdiction and your practice right now, their health, your health, the public's health, what's going on where you live. But I think generally we start off doing the same type of good, safety assessment that you would do in person, documenting that, being thoughtful about the level of care that's appropriate for the client and whether or not you feel you can fulfill that period, also in addition to telemental health, in the telemental health milieu. So in some circumstances, I'm then looking to augment the care that I'm giving, with something additional. I want to acknowledge there's some pretty great, and we'll talk about this next time, apps and programs that augment safety planning that are really nice partners in telemental health. The app I really like these days is My3, that does a suicide safety plan. Another colleague who's actually work I'm going to talk about in a moment is Ursula Whiteside's website, Now Matters Now. I think there are augments, that we can look to in the telehealth space. But at the end of the day, I handle it much as I would in in-person care. I'm assessing safety, I'm assessing imminent risk, whether or not I need to refer them, for emergency services, or whether we're going to handle this on an outpatient basis. I'm assessing appropriateness of level of care, and if I think additional treatment is indicated either with me, with a colleague, or, with some sort of adjunctive care.
And I'm noticing that we're about 20 minutes to the top of the hour.
Yep.
Back to your session.
Okay, let's do it.
Okay.
Let's finish it up. Okay, we're going to talk a little bit about when things go right and when things go wrong. When things go wrong, I think when our calls drop, and again, I'm going to go quickly here because we've spoken about some of these themes previously. We want to make sure if we're doing a video conferencing call that we have a telephone handy, that if internet's out, we can call them on the telephone. If we're already on the telephone, we want to try to get an alternate number if one is available. We want to try to have an alternative platform for video conferencing in case one of it is failing. And again, we want to be pretty nimble in switching between the modalities if, again, that is what is appropriate for our client and well matches the level they are at. We want to have covered these themes already in our informed consent and talked through what are we going to do if there's a technology failure. Keep calm, carry on. I find that people are very gracious and generous, particularly if we just kind of laugh about it and say well, we do the best we can. Some candor and some levity, I think, go a long way when things go wrong. I really want to, validate client frustration. And, particularly if the client's thinking about terminating because they are frustrated about the modality. I think there's this opportunity to really join with them. If you're having frustration too, I think it's okay to share that. I think that builds rapport and honesty, to disclose your experience of what it's like to try to be in connection with them over the modality, where that's great and where that's really hard. I think we iterate and we experiment. I backed up the camera, I've backed off the camera, I've gotten closer to the camera. One client recently, I just transitioned to telephone because the lag that was happening on the video was just too much. And on the telephone, they felt much more connected. The rapport was much better. And we weren't having all these hang-ups and delays that were happening over the video conferencing. So I think really, again, that candor, that honesty, and really just being present, joining with them where they're at, not judging it, and trying to just be present with it. when things go right, there are opportunities specific to this milieu. We get to see clients' homes. We have better access to their collateral reports. And I think it's a harder argument for avoidance. I think I've had folks where they come late to session, because of traffic. And I live in Seattle. There's a lot of traffic. That's really valid. And when it happens again and again and again, I'm starting to have conversations with them about what it's like for them, to come to therapy. And I'm wondering if clinical avoidance is an issue. That is happening less in my telemental health. I'm not saying that folks haven't no-showed me. I have had no-shows, and folks have, said that their time is now totally undifferentiated and Kafkaesque, and they, no longer really know what day is Tuesday. So, but again, if that happened a bunch, I would be thinking about avoidance. But I do think that over the telemental health milieu, care is so accessible, there are fewer opportunities to fall into avoidant patterns, which isn't to say people can't. I want to take a moment to talk about caring letters and caring messages. And this is a program that is being offered through Northwest ATTC. Basically, this is going to be a product that they are offering on their website, and you're going to see that website right on the bottom there, attcnetwork.org/Northwest. So this is a new online training. This is going to be a self-paced curriculum. It's going to take you about an hour to get through it. There's about 50 slides. It outlines the origin and the empirical basis for the Caring Messages program. This is a program that seeks to reduce client isolation and potential self-harm through messages that reach out to clients post-hospitalization. This focuses in part on the special circumstances and populations for which and for whom care, engagement, and retention can especially be challenging. And it includes concrete examples of caring contacts, as well as modifiable templates that are downloadable from Northwest ATTC's website. We're talking about this in the context of telemental health. This is really the Caring Messages program is an outgrowth of the Caring Letters program, which maybe folks have heard that language before, as a post-crisis suicide prevention program. And this is very research supported. There's great data on it that really suggests it helps reduce future incidents of self-harm and returns to the hospital. And why are we talking about this in the context of telemental health? This is another product that Northwest ATTC is offering, and I think it's a wonderful one. But I think this also deals with when we're connecting with clients at a distance. We're talking about themes of engagement, alliance, and really communicating our rapport and our good intention to clients, even through the written word. The impact of human caring, I think one of the things that I find most prominent in telehealth is your care for your client, your investment in their well-being really can transcend physical space. People can feel that. They can feel that over the telephone. They can feel it over video conferencing, and they can feel it in a letter. I also want to point to another website that I think is really lovely, Now Matters Now. I spoke about it earlier. That does a really nice job of providing supportive videos to folks who've had suicidal ideation in their life, and I think just does a very beautiful job. Dr. Ursula Whiteside, who's another Seattle psychologist, oversees this, and she's just wonderful, has done a lot of beautiful work in the intersection of telehealth and suicide prevention. Okay, let's talk a little bit about why these themes of rapport and engagement in telemental health are especially salient in this era of COVID-19. So, we are starting to see some of the data I'm sure folks have seen suggests the significant uptick in mental health need. Clients need help. People need stress. We are seeing higher substance use. We are seeing higher ideation regarding self-harm. We're seeing increased depression and anxiety. And this is happening in tandem with a very significant decrease in the availability of in-person services. Many jurisdictions may have stay-home orders. You may or may not be regarded as an essential worker in your jurisdiction, so our ability to provide those in-person services nationally is diminished. This is the shared moment of crisis. I think that is a shared human experience right now. So I think, when we're thinking about clinical engagement in telemental health, we have this ability to bring accessible services to clients who really need it. And we have this ability to connect with another person authentically and to support caring and rapport during a time of crisis. I want to acknowledge that I find it very hard to diagnose things right now. I don't know about you guys. When folks come in and tell me that they're anxious and they're hand washing and they're hypervigilant, there is this really big part of my brain that is saying, well, yes, that seems reasonable to me. Perhaps I'm revealing too much about myself clinically. But I think, anyway, I think there is this moment to really connect with people in the middle of a crisis and be present with our clients. You know, and I think therapy's role is diversifying in the context of COVID. There's care as usual. You know, I'm seeing some clients for, you know, their OCD or their panic disorder, or, you know, they're engaged in relapse prevention planning, and we're doing that. I think I'm doing more around crisis management these days because people are more distressed in the context of COVID. And, you know, for many of my clients, we are talking more about their isolation and the manner in which the quarantine has impacted their behavioral health. They're not able to go to the coffee shop. They're not able to see their family. They're not able to, you know, hang out with their coworkers. These little things that really used to support their behavioral health. And I really think that therapy is, now we're serving this dual function, not only, you know, delivering care specific to the issue that they're there to receive care for, but then in addition, we are addressing some of that social isolation. And again, you know, 6 months ago, I would have maybe had a huff puff and said, well, I don't know, is that the best use of therapy? And, you know, therapy's there to address clinical issues and da 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 da. But right now, I think it's an incredibly important role for therapy. A lot of my clients, you know, they are not connected in the outside world right now. And I think they really don't have as many options and choices. And I think that if therapy can help bring into their life some connection and engagement and rapport, that is an incredibly valuable service. So in summary, we've talked about a lot tonight. We want to think about your space, the client's space, and that which connects them, the technology environment. We're going to think about how to minimize distractions, noise, clutter. We're going to minimize technology challenges. We're going to try to make that environment accessible, warm, but still visible and easily consumed. We're going to establish expectations and support good boundaries. The struggle is real. You know, Zoom fatigue is real. Client frustrations with the modality are real. There are a lot of awkward moments, you know, that just happen. Things lag. I've accidentally spoken over folks so many times because of video lags, and it's frustrating. And I think candor, levity, informed consent, you know, and slowing it down really do help. Really making sure to ask questions. I pause much more in the telemental health milieu than I do in person. I'm a fast talker, but in telemental health, I really try to be very intentionally slow to give people time and to make sure that technology lags aren't going to result in me interrupting someone. That's a good question. I would just want to go over a few previously submitted questions I thought were particularly interesting from the prior week. Billing. This is something we're really going to dig into in a future class, but I did receive a question. Are there specific billing codes for telemental health? And my quick and dirty answer is yes. The telehealth location code, that place of service code, if you deliver in-person care, that's going to be 11 for in-office, but in telehealth, it is 02 to indicate a telehealth environment. And the modifier code that goes on your CMS 1500 form, if you know the form, and if you don't, please don't worry. This is just some insider baseball talk, but we are going to really dig into this, and I'll show you screen grabs of the forms in future classes. But that modifier code will be 95. We use all the usual CPT codes. So if you're seeing someone, let's say for an hour-long therapy session, that's a 90837. And I will say, always check with the insurance. If you bill insurance, check with the insurance, because I have received such wacky counsel from these companies telling me that they want me to use the old way of doing it or the new way of doing it. So it is worth your time to check. This is the technically correct way to do it. Whether or not that's what the insurance company wants is a separate matter. Fees. Folks have asked me, do you charge an additional fee for telehealth? And I really think that's a personal question. Some folks do assess a surcharge, you know, and I think their argument would be they're paying for the technology products that they purchase to support telemental health. I'll share with you, I don't, and I especially don't right now. I never do though. I mean, for me, I love this modality and I would buy those products anyway. I believe in them. So, you know, I don't have additional cost. I would be subscribing anyway. So, you know, I especially think right now we're not really clear on what the financial impacts of COVID-19 are going to be. And I'm not seeking to introduce any additional cost into my clients' lives. So, and I don't mean to be preachy about that. I think it's a totally valid thing to do. If you need that to support those technologies and buy the right kind of products, then absolutely, you know, add a surcharge. It doesn't happen to be my practice. Okay, so I think we have about 5 minutes left. We can do that final, well, maybe less, because we have to talk about how they get their CE. But David, do we have a couple more questions we should touch on?
Yes, there was one from the previous question and answer time, and it fits really well with some of the summary parts. In particular, Gilbert wrote, with the new medical marijuana and recreation, what's your response to the client who lights up during a session?
Hard no would be my answer. I think that I don't know. I mean, again, if I felt we would have a conversation about that in my informed consent document, I actually do say that substance use prior to a session will be grounds for me terminating the session, and actually they will have to pay for that session, which some people have very different policies. I'm not saying that should be your policy, but I also treat a lot of SUD, and so for me, that's going to be a deal breaker. I understand that people may use cannabis for medical purposes, for chronic pain management, for glaucoma, for all kinds of very valid reasons, and there are, of course, cannabis strains that are lower in THC that are not going to be as intoxicating. So I think I would want to have a conversation with the client about, what role cannabis plays in their life. Is it a medical? Is it a recreational, drug that they're using? And, what schedule do they use it on? Do they experience any intoxicating effects? And if so, discussing whether or not it is possible to schedule our sessions so that it is distal from those times where they're consuming it and feeling intoxicated, because I don't think it's an appropriate way to be having our therapy.
You said that very, very nicely, Sarah.
Well, thank you.
Yeah. So one more question here from Kimberly. Is there a good source of Word document worksheets for in-session exercises?
For in-section exercises in Telemental Health?
Yeah, like I think telehealth exercises, like things you would do in an individual session or a group session.
I mean, clinically, I would say we're doing very much the same thing that we would be doing in person. So I would usually be doing the same types of interventions and exercises I would do in person, adapting them, of course. If I'm having, I'm trying to think of what doesn't fly. I guess if I had people hold hands, I've never had people hold hands, but if I did, that couldn't work. There may be some adaptation that's required. I do want to mention some great one-page resources. Again, samhsa.gov has a really nice document that you can give to your clients to help them get ready for a telemental health appointment. And that was on our last class, if folks are looking for a screen grab of that. And then I really like the American Insurance Trust's template for telehealth informed consent. I think they do a really nice job. They also have an informed consent for returning to in-person services, which is, I think, a very nice addition. And they have emergency planning documentation templates there as well. As for telehealth specific exercises, actually I'm not familiar with any. I think mostly, we're thinking about whatever the usual clinical services we deliver, and then we're thinking through what adaptations would be necessary. The one exception I will say, would be assessment. If you have a formal assessment practice, then, those companies are really scrambling to get those online versions available and to think through how they can adapt them to distance milieu. So I'd say that's a whole other category and something I think we covered in class 2, perhaps.
Okay. And you know what, Sarah, I'm thinking that Kimberly had a little bit more to this question, and so we'll capture that one later, and maybe that would be something we can look at for the next session. And I'm thinking we're kind of tight on time. Shall I start wrapping up here?
Thanks, David. Thanks so much. I appreciate it.
Okay, so for a little bit of the wrap up, one in particular is if you're here, you will automatically get a certificate of attendance. We have your email address, that'll get mailed to you. If you are watching this and you are part of a group, please send us an email with the names and the email addresses of the people that were with you, and we will make sure that they get a certificate for attendance also. And a few seconds ago, I dropped a message in there for our evaluation. We'd love to get your feedback. If you'd please fill out the eval, that would be wonderful. Doesn't take very long. And the other thing is, we're going to follow up with you. I think it's tomorrow, pretty sure. And it'll be an email with the eval. That is another opportunity to complete that. And we'll also post the recording of this session to the ATTC website. And I want to give a big thank you to Jennifer Verbeck. She's behind the scenes for all these trainings, and she's making sure the tech works for us. And these slides sometimes automatically move, and that's our thanks to Jennifer, who's doing that kind of work. And with that, I'd like to say a big thank you to Sarah for another very interesting session. And I'd like to invite all of you to join us on June 9th. The title of that one is Emergencies, Disruptions, and Pitfalls in Telemental Health. And with that, I'd like to give Sarah a big virtual thank you, and also to all of our audience members. Thank you very much for hanging in there. There's still 120 of you that hung on for an hour and a half. So with that, Sarah, anything else?
Just thank you. Thank you so much, David. Thank you, Jennifer. And thank you so much to everybody who came and spent 2 hours of their time in various time zones. I really appreciate your spending your time with me. It's your most precious resource. And I hope to see you again.
Okay. See you guys all next week. Thank you.